Hey there, it's Dr. Atkinson, and today we're talking about magnesium, the drama queen of electrolytes. She doesn't always hog the spotlight like sodium or potassium, but when she decides to act up, she can take the whole show down with her. Magnesium is that friend who's in the middle of everything, but somehow still low-key about it. She activates hundreds of enzymes, helps you metabolize carbs and protein, keeps your muscles and nerves playing nice, and even influences your heart rhythm. She's the behind-the-scenes boss of neuromuscular function and cardiovascular tone. Most of her is hanging out in the bones, some is bound to protein, and the rest is free-floating in the blood. Ready to cause trouble if the levels drift too high or too low. The normal magnesium level is 1.8 to 2.6 milligrams per day years. Drop below that and we call it hypomagnesemia. Go above that and you've got hypermagnesemia. Both can turn into medical soap operas if you're not paying attention. Part 1, Hypomagnesemia. Let's start with the low side. Hypomagnesemia happens when serum magnesium drops below 1.8. It often shows up with other diva friends like hypokalemia and hypocalcemia because their balances are linked. Why does this happen? The usual suspects include GI losses, chronic diarrhea, fistulas, malabsorption, bowel resections, inflammatory bowel disease. Alcohol withdrawal. Up to 2/3 of ICU patients in withdrawal have it. Refeeding after starvation. If you restart nutrition without enough magnesium in the mix, the cells suck it up fast. Medications. Diuretics, aminoglycosides, amphotericin, cisplatin, cyclosporin, PPIs, even rapid transfusion of citrated blood. DKA, you pee it out during osmotic diuresis, then insulin shifts it into cells. Symptoms. When magnesium gets low, your nerves and muscles get a little overexcited. You might see positive Schwastek's and Trousseau's signs, tremors, hyperreflexia, and if it's bad, seizures. Psych symptoms can pop up too. Anything from mild agitation to full-blown hallucinations and psychosis. Cardiac effects. Prolonged QRS, depressed ST segment, PVCs, torsades de pointes, even ventricular fibrillation. And if your patient's on digitalis, low magnesium makes them more vulnerable to toxicity. Diagnosis. Serum magnesium below 1.8. If you've also got low potassium or calcium, you can't fix those until you replace the magnesium. Nursing priorities. Watch at-risk patients closely, especially those with alcohol withdrawal or big GI losses. If they're on digitalis, be extra careful. Seizure precautions if it's severe. Screen for dysphagia so they don't aspirate. Educate on magnesium-rich foods, green veggies, nuts, legumes, bananas, oranges. Part 2, Hypermagnesemia. Now let's flip it. Too much magnesium. Hypermagnesemia means serum levels above 2.6. It's rare because the kidneys usually dump the excess, but if those kidneys are broken, magnesium can pile up fast. Most common cause, acute kidney injury. Other causes, untreated DKA with oliguria. Too much magnesium given for eclampsia or to treat hypomagnesemia. Addison's disease, adrenocortical insufficiency, hypothermia. Magnesium-based antacids or laxatives, especially in patients with slowed gut motility. Lithium toxicity, massive tissue injury, trauma, sepsis, severe burns, cardiac arrest. Effects. Magnesium is a nervous system sedative. Mildly elevated, you might see flushing, hypotension, drowsiness, muscle weakness, and hypoactive reflexes. Higher levels bring respiratory depression, 10 milliliter coma, atrioventricular block, cardiac arrest, platelet clumping, slowed clotting, and worsening arrhythmias. ECG changes, prolonged PR interval, widened QRS, peaked T waves, prolonged QT interval, heart blocks. Management, prevention. Avoid giving magnesium to patients with kidney injury unless necessary and monitor closely. If high, stop magnesium sources. Emergencies, IV calcium to counteract effects. Dialysis with magnesium-free fluid for severe cases. Loop diuretics with fluids if kidneys still function. Nursing priorities. Monitor vitals. Hypotension and shallow breathing are red flags. Watch cardiac monitor for bradycardia and heart blocks. Check neurostatus and deep tendon reflexes. Avoid magnesium-containing meds in patients with kidney issues. Teach patients with kidney disease to check with provider before OTC supplements. Track INO if getting diuretics or fluids. Part 3. Quick compare hypomagnesemia, jumpy nerves, irritable heart, high reflexes, seizures, arrhythmias. Hypermagnesemia, sleepy nerves, slow heart, weak muscles, low reflexes, risk of arrest. Both are dangerous. Both need quick recognition and targeted management. And both will drag other electrolytes into the mess if you don't correct magnesium first. Moral of the story? Respect Magnesium. She may not always demand your attention, but when she does, she expects you to drop everything.